Thank you very much. And thank you to Nasser and the organizing committee for the very kind invitation to this meeting and to speak today. So I'm going to speak about endoscopic third ventriculostomy with choroid plexus cauterization for infant hydrocephalus, which I think is one of the more fascinating topics in pediatric neurosurgery these days. I think we all know that targeting the choroid plexus as a treatment for hydrocephalus is not new. This is something that's over 100 years old, and there's many reports from the early part of the last century of either choroid plexus cauterization or plexectomy for hydrocephalus treatment. The results were really quite poor, high morbidity and even mortality in those cases. And then in the latter half of the last century, as CSF shunts became more popularized, CPC really fell by the wayside and was not really part of mainstream neurosurgery for the most part. But there was a resurgence in the early part of this century with Ben Worf's work, where he presented his large experience of the unique combination of ETV with choroid plexus cauterization for infants that he treated in Uganda. And this was a seminal paper that he published now nearly 20 years ago, where he describes a technique of using a single unilateral coronal entry point, flexible endoscopy to perform the ETV, and then using the flexible scope to complete choroid plexus cauterization of both lateral ventricles and creating a septostomy in order to get to the contralateral side if necessary. And the experience now in Uganda is astounding, and they've treated thousands of infants there, and that they've published a number of papers. If you were to summarize it, what they've shown is that adding choroid plexus cauterization to ETV improves the chances of ETV success in a wide range of etiologies of infant hydrocephalus, including post-infectious hydrocephalus, myelomeningocele, and many others. And that set the stage for a randomized trial that we did in Uganda a few years ago that's still ongoing in terms of long-term follow-up. But that was a randomized trial of post-infectious hydrocephalus specifically, and it showed no difference in the 12-month developmental outcome or in the 2-year developmental outcome comparing ETVCPC versus traditional shunt. So what's happened in North America for this? Because it's an interesting story as to how this, this procedure and this technology has transferred from Africa to North America. So there's a number of papers now that have been published on the North American experience with ETVCPC. This is one of the larger ones, and this is Ben Worf's work, so the individual who really developed this procedure after he came back to the United States. This is his experience in Boston, where he showed quite good results. So the middle line there shows his primary success rate. So using ETVCPC, roughly a 50% success rate, and then in a proportion of those, he's able to reoperate on some of the failures so that ultimately it's a nearly 70% avoidance of shunt, if you care about that outcome, whereas his shunt success rate looked quite a bit lower there in red. Now, we also studied this in North America through the Hydrocephalus Clinical Research Network, and this is a network of 14 clinical centers across North America who study hydrocephalus either in prospective or sometimes retrospective studies. And if you look across our network at how popular this procedure is, you can see that it really didn't start to become popular until 2012 and then certainly by 2013. And what happened at that point was a number of the surgeons in that network, myself included, we went to Uganda to learn the procedure from the surgeons there and then brought the technique back to our centers in North America. And since then, we've been doing several dozen cases a year, several hundred cases in total since we began, and have developed quite an experience with this. But we first published our early experience. So these were the first roughly 120 cases that we did. And you can see our results were not as good as what Dr. Worf was able to show in Boston. Our primary success rate was under 40% for this patient population. And when we compared that to this is not randomized data, but a matched cohort data, if you compare that with shunt, the results were not very good in terms of at least success rate. Shunt certainly looked better than ETVCPC for these infants. So as we started doing this procedure, we were offering it on a wide range of infants because the indications of which specific infants to offer it on in the North American population was not very clear. But there was strong interest in this procedure, and it often came from families who would come to us demanding this procedure. They'd read about it, they'd seen it on social media, and they wanted it as an alternative to shunt. And even if you told them that the success rate was poor, that was something that they would still really advocate for. So at that time, the role of ETVCPC in infants in North America really did not have a strong evidence base. And we started to develop our own sort of personal indications for this based on some of the data that we had from the Hydrocephalus Clinical Research Network. And this is, a few years ago, sort of my personal general indications for this procedure. I would generally offer it in infants who are under 2 years of age. And then the age cutoffs would depend on their etiology. So those who had myelomeningocele would need to be at least term-corrected age. Those who had intraventricular hemorrhage of prematurity had to be at least 6 months corrected age, which is, as you can imagine, quite a rare population. They don't usually make it till 6 months corrected age before needing hydrocephalus treatment. And then for most other etiologies, I would consider it at 1 month corrected age or beyond. They, of course, had to have favorable third ventricular anatomy. And importantly, we would do sagittal cysts or fiesta images to make sure that there were no obvious prepontine adhesions, like I'm showing you here in these 4 panels, where there are in fact adhesions in the prepontine space and would not be good candidates for this procedure. So at that time, as we were doing this procedure over a few years, major questions arose about this, such as, is there a minimum age under which the success rate is too low to even offer the procedure? Maybe that's a 1 month cutoff or a 3 month cutoff. Or for what etiologies is the success rate so poor that you shouldn't offer it? But related to that, and maybe even more important, is how low a success rate are parents willing to tolerate for the possibility of shunt freedom? And this is a difficult thing because once the families get on social media and start reading stuff, they get very set on avoiding a shunt, which may or may not be the right thing. That's a whole separate talk on the evidence of shunt versus endoscopic treatment. But for a lot of them, they're willing to take a very low success rate for the chance of avoiding a shunt. And the other big question that we never answered was, are there long-term cognitive effects of this procedure compared to shunt? As we know, even when this is successful, the ventricles remain large. What's the long-term impact of cauterizing the choroid plexus on cognition? We don't have good answers to that. And so it seemed that the timing was probably right for a randomized trial comparing ETVCPC to shunt in the North American population, much like we had already done in the Ugandan population. And it seemed like the timing was right because we had grown our experience in this procedure. There is a learning curve to this procedure, and I think at this point we were feeling quite comfortable with how to do it. But it was not so well established that it suddenly had become the standard of care, which sometimes happens with procedures that become popular and then without evidence become the standard procedure for a given condition. So it seemed like we were at the right point for doing that. And so we went through a few rounds of trying to get funding for this trial with the National Institutes of Health in the United States, and ultimately we were successful. This is a large study. It's a 7-year multi-center randomized trial, and it's going to cost close to $10 million US to complete this study. The primary study question that we had was in infants under 2 years of age with hydrocephalus requiring treatment, does treatment with ETVCPC compared to shunt result in a non-inferior cognitive outcome? So this is a study where the primary outcome was cognitive, but we were also looking at a whole range of other outcomes, including detailed MRI and other imaging biomarkers, CSF biomarkers, quality of life outcomes, and resource utilization. So it was a very comprehensive assessment of outcomes in many different realms. The inclusion criteria, we are including only patients who are over 37 weeks gestational age, but under 2 years corrected age, and with no prior history of hydrocephalus treatment. We're excluding infants with intraventricular hemorrhage or prematurity, which is something that I didn't want to do when we started this study, but when we put it through the NIH granting process, they actually demanded that we exclude these patients, and there's some rationale to that, but I think it's a missed opportunity, unfortunately. And of course, we're excluding those who have moderate to severe prepontine adhesions on MRI, like I'm showing you here, because we know that the success rate is quite poor. Now, we anticipated that there was going to be problems with randomization. Families are loath to randomize when it's a surgical trial, and there's two quite different types of surgeries. And so we instituted what's called an equipoise panel into this study, where the case details of each child are reviewed by an independent panel of 16 pediatric neurosurgeons, who then vote to decide, do they feel independently and individually, is this patient suitable for both procedures? That means they could be randomized. We get those results back in about 12 hours, and then we review it with the family before they agree to randomization. But you can see some of the difficulties that we have with this. So if a family is approached for the study, about half immediately refuse. They want nothing to even do with the study because they've already decided what procedure they want. They don't want to hear anything else. Of the 50% who still are undecided and then go for the review by the panel, we offer almost all of them randomization, but then only half of those choose to be randomized because instead they decide that they want one procedure or the other and don't want to leave it up to chance. So when you run the numbers, as of April of this past year, we screened well over 1,000 patients. About 350 were deemed eligible and were approached. Of those, 180 were offered randomization, and of those, only about 90 were randomized. Currently, we're up to about 120 patients randomized, which is pretty good, so we're getting closer to our target of 176 and getting there slowly. And you can see the difference here in what we anticipated or what we expected to be our recruitment rate in the dashed line there, which if we had followed it, we would have completed recruitment by now. But of course, recruitment has been much slower than that, and so we're on the less steep curve here, and we anticipate that we will end recruitment in 2026 instead of 2024. If you look at the patients that we've randomized so far, that's a very young population, so even though our upper age limit is 2 years, in fact, the vast majority of children are under 6 months, and a third of them are under 1 month of age. And in terms of etiology, the biggest group is myelomeningocele. Again, remember, we excluded intraventricular hemorrhage or prematurity. So the biggest single group here is myelomeningocele, followed by aqueductal stenosis. And amongst the myelomeningocele patients, 2/3 are postnatal closures and 1/3 are prenatal closures. So in conclusion, I think the role of ETVCPC in North American population is still being determined. This randomized trial that we have is ongoing. We're still a few years away from primary results of it. It is an essential trial, I think, but recruitment for these types of studies can be challenging, as I've showed you. But I've also showed you ways ways that we're trying to improve on this recruitment, and I think have been doing well so far. RCTs of this size require patience and require significant financial and labor resources. This is an expensive and long-term study, but I think the results in the end will be worth it. Thank you very much.